You've probably heard someone say, you know, everyone has parasites, and that you need endless anti-parasitic protocols that might go on for the rest of your life. Today, we're going to focus on what the science actually shows, why truth is more nuanced than these slogans, and how to talk honestly about this in your clinic, and how to talk about this honestly with your patients without losing clinical creativity. This isn't about denying that antiparasitic treatments can help some chronically ill patients. Many clinicians, including myself, have seen that. Many patients, they've experienced that. What this is about is clearly separating what we know from what we're guessing so that we can protect patients and protect the credibility of integrated medicine. I've also heard people say, hey, 90% of the people that get colonics in my practice have parasites. Do you know why? I see them in the water. Well, the problem with this is they never take those parasites and send them off for identification. So they're just asking us to trust them. When we make claims that we can't back up, we hand ammunition to people who want to dismiss everything we do, including the parts that are based on solid ground. By the end of this video, you're going to understand three really important things. Number one is what the epidemiology actually shows about parasitic prevalence. Number two, why 90% of patients have parasites is scientifically indefensible. And why antiparasitic treatments can still work even if we can't prove that someone has a parasite there. So in my years of training healthcare practitioners on evidence-based approaches to complex infections such as Lyme disease and co-infections, there's really one clear theme. Clinicians who thrive long-term are the ones that combine clinical creativity with scientific integrity. So let's dive in. Let's talk about this. What's myth versus what's epidemiology? And here's the hard truth. Current data does not support the blanket claim that everyone has parasites. In fact, a recent prospective study in France and Luxembourg looked at over 2,000 patients coming to primary care clinics. These weren't travelers. They weren't people who lived in high-risk environments. They're just everyday patients, right? And what they found was that about a third of them, 33.2%, of these patients had intestinal parasites. However, only about 7% of those were pathogenic, right? So these are the parasites that are causing real disease in your patients. You know, 7%. That's not everyone, and it's certainly nowhere near 90 to 100% of people. And yes, in symptomatic populations, such as ill returning travelers, the prevalence is much higher. I've seen this in my patient population. Though they travel to an area where we expect that they may have exposure to parasites, they develop, gastrointestinal symptoms, we treat them, and they get better. But even there's only a subset of patients that are really truly positive for specific parasites on their stool test. And in medical reviews of intestinal parasitic infections in developed countries consistently show that while parasites are important, they're not universally present in all symptomatic patients. So what does this mean in practice? Well, parasites are common enough that we should be thinking about them and have them in our differential diagnosis. They definitely deserve appropriate testing and targeted treatment when found. But the epidemiology just doesn't justify the universal claims that virtually everyone is infected with a parasite. And it's my opinion that we have to stop swinging from one extreme, parasites don't matter, to the other extreme, hey, everybody has parasites. And really, this nuance is what separates strong, evidence-based integrative medicine from claims that are easy to dismiss. Next, I want to talk about the true diagnostic limitations we see and why this is not licensed for pure fantasy. The reality is, this diagnostic dilemma is real. The CDC's Yellow Book and infectious disease researchers, experts, they review this and acknowledge that standard questionnaires and routine labs for parasitic disease have significantly limited sensitivity and specificity, and that they actually miss true infections. And this matters because under-detection is actually real. However, where things go totally off the rails is when this limitation gets turned into, the test misses things, and therefore everybody's got parasites. And therefore, I no longer need to test you because, I think your symptoms, they sound like parasites, and since everybody's got them, we might as well treat you. That's just not how science works. And frankly, at this point in my career, being in medicine for over 30 years now, I'm sick and tired of this crap because we are taking patients with real problems And we are marginalizing them and all the practitioners who are open to identifying what's wrong with them because everybody's got a parasite. It's a bunch of crap. So as much as our microbiology and infectious disease guidelines need to be upgraded, and we need a lot more research and money poured into research in infectious diseases, the guidelines are helpful, and they are really important because they emphasize proper specimen collection, appropriate test selection, expert microscopic and molecular examination. Those aren't bureaucratic hoops, they're the backbone of ethical diagnosis. Ethically sound approaches look like this. The best case. Hey, we did a test, we have lab confirmation that there is a parasite there. Here's our treatment plan. And then we don't get that really solid diagnosis that we're all looking for. The transparent case, right? Where we're honest. Your symptoms fit a pattern where I've seen antiparasitics sometimes help. We may not be able to completely prove that a parasite is present, but here's what's known, here's what's uncertain, and this is the risk-benefit profile. So let's decide together whether a careful trial with short-term reassessment makes sense. And what's so great about this approach is it respects patients' autonomy and their intelligence, and it also respects our ability as clinicians to innovate clinically, use our experience, use our creativity. But it's not just saying we're going off the deep end and saying you have a parasite. What it's saying is you may have one, let's do a therapeutic trial of treatment and reassess you. Because on the opposite side, ethically unsound is, you definitively have a parasite, the tests are useless, you don't even need to do them, and the one you got that was negative, it's a waste of money because we know what's there even if nothing shows up. And the problem for me is this isn't medicine. This is magical thinking dressed up as certainty. We're making up stuff, pretending to know the answer. Requiring proof when possible or being explicit when the proof is lacking isn't closed-minded. This is how ethical medicine is practiced. Now, let's talk about this. Hey, 90% of people coming through a clinic have parasites that are seen in their colonic water. This is a crazy claim to me because if I were to run a colonic on somebody and I were to see a parasite in the tubing or the water, I would get that and test it because you found it. If it's a real thing that you see, you should be able to send it to a microbiologist and find it. And so if that statement that 90% of people who go in and get a colonic, that you see a parasite in that water, in that tubing, if that were accurate, this would be one of the most important public health findings to date. Not this decade, not this millennia, like ever. So if it were that important and it were that real, why wouldn't you find out? So I'm gonna make an invitation to any of my colleagues out there who are making this claim. Collect the material, let us know, preserve it properly. Send it to a lab where they actually have trained parasitologists who will do microscopy, antigen testing, and DNA testing. And then publish those findings. Because if those specimens are confirmed parasites, it would change the entire conversation instantly. Skeptics would have to engage with this new data, and many people would welcome that evidence, including myself. But then someone talks about ropeworms, right? And we found these things and we submitted them, but the analyses to date typically identify the structures as mucus, sloughed off tissue, or intestinal debris rather than true parasites. Health-oriented reviews and medical commentary consistently point out that there currently is no peer-reviewed, well-documented evidence that ropeworms are a recognized human parasite. Endoscopy and colonoscopy literature follows the same principle: visual impressions, mucosal changes, or visible organisms must be correlated with lab confirmation before diagnosis is made. So you really can't build a solid diagnostic claim based on visualization alone. So at this point, claiming that 90% of your colonics are showing parasites without confirmed lab evidence is just not scientifically defensible. The issue becomes, and these claims are made loudly and repeatedly, they damage the reputation of integrative medicine as a whole, and they restrict access to appropriate integrative care to patients who are deserving it. So the responsibility is on those who are making these claims that would change the status quo to do the hard work to prove their claims. None of us are saying you're wrong. What we're saying is currently the evidence does not support your claims, and so the onus is on you to provide the new data that proves and supports what you're finding. This is exactly what's gone on with specialty labs in Lyme testing. They've done rigorous testing to prove what they've said for decades, but it took them that long to actually prove it. So they took the higher road and went for it. So I invite all of you who think that parasites are a bigger issue than the medical literature claims to hop on board and bring other people in, do the studies, but the onus is on you to make this change in medicine if you're the one who's out there saying it. Saying these things, these crazy, fantastical things, without having the evidence to back it up, not only hurts all the other doctors in functional and integrative medicine, but most importantly, it hurts patients. So what about when people come in and you have a therapeutic trial of an antiparasitic, or maybe you have a friend who's gone and worked with somebody who is unscrupulous, but they gave them an antiparasitic for the wrong reason, but they still saw benefit. So what happens? Why could an antiparasitic help even with a negative test? And to me, this is where it really gets interesting, because I say all the time, I'm open to the fact that these things are working, but I want to know why. So if I can't prove there's a parasite there, maybe there's another mechanism, and that's super interesting. Even though we know that there's all these limitations, myself and so many of my colleagues, so many of you watching know that antiparasitics can help some people who have a negative stool test. In a retrospective study of returning travelers with persistent abdominal symptoms and negative stool tests, where empiric treatment with tinidazole plus albendazole was used, about 69% of those patients reported improvement in gastrointestinal symptoms, and many also reported better energy and overall well-being. Now, what's interesting to me about all of this is that the authors concluded that in this context, an empirical antiparasitic trial was justified, but they never claimed that this proved that parasites were the cause in every case. This is awesome because this is conventional medical literature. This isn't functional medicine. This isn't me telling you this in a YouTube video or on Instagram. This is literally medical research. So I'd invite you to go read it because it might actually guide where you're going. Let's think about this. Why might this be happening with antiparasitics? So what might be happening when antiparasitics help in these situations? Well, the literature really supports several plausible mechanisms. And the first one is the one that I've seen probably be the forerunner for a very long time, and that's called immune modulation. Certain antiparasitic drugs have immune modifying and anti-inflammatory properties, and that go beyond just killing worms, right? So they can influence pathways related to inflammation, oxidative stress, and even tissue signaling. And this can help translate into symptom relief even without a clearly defined parasite. And one of the most commonly sort of referred to medications along this vein is ivermectin, right? We've seen it used for so many different things. And yes, does it have antiparasitic properties? Yes, absolutely. Worms, yes. Even babesiosis, yes. However, there's so many immune modulatory properties it also has that's one of the reasons it may work. Now, one of the other reasons that the scientific literature supports that antiparasitics could work in situations where we can't identify a parasite is really modulation of the microbiome. And reviews of common intestinal parasites suggest that organisms such as Blastocystis and Dientamoeba fragilis can frequently appear in healthy individuals and may function more as commensals in many hosts, and treating them can reshuffle the gut microbiome. So sometimes this leads to the person feeling better, and sometimes it doesn't. So it's not always as simple as I see something that's bad or could be bad and I kill it, and then the patient will be cured. So the story's a bit deeper than that. But many of us have seen people with persistent GI symptoms where you treat Blastocystis or Dientamoeba species, and you see the people get better. But we've also seen people where it doesn't work or they get worse. So again, it's worth trying if you find these, but just be aware that telling people that Blastocystis treatment is going to fix everything may not be the most accurate statement you make that day. So one of the other reasons that these antiparasitics may work is Host-Parasite-Microbiota interactions. So some recent work has really described complex interactions between parasites, the microbiome, and the host immune system. Antiparasitic treatment may change the parasite burden, alter microbiome composition, and modulate immune responses simultaneously. So it's kind of like combining number one and number two, and now here we are, we're creating clinical changes even when a single culprit is hard to identify. And this is to me, one of the most important parts of why we need to actually state fact when we know what fact is, and in most of medicine, it's not fact. So let's be honest, because when we're honest, we can say, look, there's multiple things likely going on, which is why we can't do this. If you take the case of like Lyme disease and Babesia co-infected mice, we know how much Lyme and how much Babesia is put into these mice, but you can't find the Babesia almost at all. But if you just inoculated that amount of Babesia, it's easy to find. And in the case of co-infection with Lyme and Babesia, symptoms are worse, they're harder to treat. When we say that, oh, we didn't find the Babesia, everybody has Babesia, let's treat it, that might not be fair. But we could say, hey, maybe we've got a host-parasite-microbiota interaction, or in the other case of Lyme and Babesia, we've got a tick-borne co-infection, and we know that when more than one thing are going on, they negatively impact the immune system and the body's overall response in very unique ways that we're just starting to understand. So that's a completely different statement to just say everybody with Lyme has Babesia, so we need to treat it. And then there is some work that's done on our fourth point here of how antiparasitics could help, is really these post-infectious phenomena. And this is one of my favorite things because this goes to post-treatment Lyme syndrome all day long. But there is strong evidence that shows a single gastrointestinal infection could trigger long-lasting functional gut symptoms. And some people call this post-infectious irritable bowel syndrome or post-infectious IBS, and there's even a post-giardiasis syndrome that happened long after the acute infection is gone. And in some of these cases, antiparasitics may help address really low residual levels of infection or act as a reset to the dysregulated gut immune axis. Now, what's interesting here when we look at post-treatment Lyme syndrome is some people probably have dysfunctional immune systems. Some people probably have really low levels of pathogens that are still causing problems, but they're below detection limits. And I think in a lot of people it's a little bit of both. The question is how much of each is going on. This is where we need more research. So it's not just in tick-borne illness, it's not just infections. Across the board, we need to be thinking about these post-infectious phenomena, whether it's immune dysregulation, really low level, hard to detect, if not impossible to detect by today's technologies of testing. So we have to start to think about this. There's more out there, and a therapeutic trial of treatment or an empiric trial of treatment with reassessment is completely reasonable. Just be honest about why you're doing it. So while hidden worms are in everyone is really not supported by the current data, the idea that antiparasitics can help some people through multiple different mechanisms is truly supported, and it deserves careful, honest discussion. And one of the biggest things for us practitioners is that all of this complexity really eventually has to land in a simple, honest conversation with our patients. So if you're a healthcare practitioner who wants to become the trusted go-to expert in chronic infections in your community, someone who can navigate all those gray areas with both rigor as well as creativity, this is exactly what's taught in my Lyme disease practitioner certification and mentorship program. There's a link in the description below where you can learn how clinicians are mentored through real-world complex cases so that they can practice at the highest level. So let's recap our three main points today. So first, everyone has parasites. It's just not supported by the epidemiology. Parasites are important, absolutely, but they're not universal. And imperfect diagnostics do not justify sweeping universal claims. Second, colonic 90% of people have parasites claims remain completely unproven until the specimens are collected, analyzed by parasitologists, and published. At present, the supposed ropeworms are better explained as mucus or debris and not confirmed to be parasites. And thirdly, antiparasitics can help through a myriad of mechanisms: immune modulation, microbiome shifts, and complex host, microbiome, immune system, and parasitic interactions, but not just by killing these hidden worms. And you know, really, the bigger picture is patients deserve our best problem solving and our best honesty. For clinicians, if you're seeing striking parasite-like findings, document them, collaborate with parasitologists, publish the data. This is how the field is going to be advanced rather than dismissed. And for patients, ask not only what your practitioner is recommending, but how sure they are and what evidence supports that recommendation. And if you get an answer saying, hey, there's no evidence supporting this, but this is my clinical experience, and you get the transparency, that's so much better than this other baloney approach to just trust me because I know and I'm the doctor. Now that you know how to approach parasitic treatment with scientific integrity, the next step is applying the same approach to other controversial topics in integrative medicine. So join me next time when I'm going to dive into another one of these taboo topics. We're going to take a super deep dive into another topic that deserves to be discussed openly and honestly. So let me know in the comments below what topics you think that we need to take a deeper dive into, and please subscribe and turn on those bell notifications. It helps our channel tremendously, and also you're going to be notified the next time that video drops. Until next time, I'm Dr. Tom Moorcroft. Have an amazing day.